Thank you very much. And I have with me my co-moderator, Dr. Rajiv Koval. And it gives me a proud privilege to introduce an old friend of mine, Dr. Guillermo Umpierrez. Dr. Umpierrez actually needs no introduction. He is known for the amount of work that he's done in the field of diabetes. Particularly, his interest lies in the area of inpatient hyperglycemia. There isn't a single presentation that doesn't carry a reference of his. Just a short introduction, Dr. Guillermo Umpierrez is a professor of medicine in the Division of Endocrinology and Metabolism at the Emory University School of Medicine, and he's the chief of diabetes and endocrinology at the Grady Memorial Hospital. I'm going to request Dr. Umpierrez to present his lecture.
Can you see my slides?
No, it's gone off, and you need to come closer to the mic. You're a little soft in your voice.
All right. Hope that you can see my
Now I
slides
can
now.
see. Yeah.
So, thank you, Sanjay, and again, good evening. In this first presentation, I will present to you how the international organization have adjusted their recommendation based on new evidence during the past 3 decades. This slide shows my potential conflict of interest. I'm the editor of BMJ Diabetes, and Emory University has received funding for different investigator-initiated studies that we have conducted. I will first describe to you the evolution of diabetes treatment goals in type 2 diabetes, review the 2020 ADA ACE algorithm. I'm the chair of the algorithm for ACE, and discuss factors that are important in applying individualized algorithm for the treatment of diabetes. And let me start with this slide. This table shows the glycemic target of the 3 major organizations in the United States. The American Diabetes Association guided treatment mostly on A1C, and we want to achieve a hemoglobin A1C less than 7. If you can do this in a safe way. The American College of Endocrinology would say it's less than 6.5. If you can achieve that with no hypoglycemia. The American College of Physicians instead says 7 to 8 for most patients. So there's some differences on the guidelines, but all of them will agree that there are 2 ways that we have to adjust therapy. In one way, seeking benefit. So patient must be asymptomatic. Do you decrease the risk of microvascular complications, and also macrovascular complications? But on the other hand, we have to be aware of risk of harm, adverse events, and of course, cost of medications. So during the past 20 years or 30 years, this is how we got here. From 1990 to 2008, the goal was efficacy. That means bring the hemoglobin A1C down. And the rationale was based on different landmark studies, like the diabetes complication control trials, that shows that with increasing hemoglobin A1C, you increase the rate of microvascular complications. Here you have retinopathy, nephropathy, neuropathy, and microalbuminuria. All of them, the relative risk increase with increasing hemoglobin A1C. And more importantly, the DCCT let us know that if you improve glycemic control to a level less than 7 or around 7, you can prevent complications. Not only the appearance, but also progression of complications by somewhere around 40 to 60%. Similarly, the United Kingdom prospective diabetes studies in patients with recently diagnosed diabetes also told us that improvement of glycemic control, although it's difficult to maintain at long term, reduces the rate of complications from microalbuminuria and somehow macroalbuminuria and complications, even the risk of death. And the UK PDS told us that it doesn't matter what level of hemoglobin A1C you start, a reduction of each 1% from wherever you start, decreases the rate of death by 20%, microvascular complication close to 40%, and the risk of myocardial infarction. So efficacy was the way to go. What happened in the last 15 years? There were several large randomized controlled trials from 2008 to 2017 that told us that the risk of hypoglycemia is associated with increased risk of complications and even death. Therefore, we came with individualized diabetes targets. So here you have data from the UK PDS, and you have different rate of hypoglycemia according to different agents. In the bottom, you have no therapy or diet therapy and metformin and the risk. And here you see that sulfonylureas and insulin is associated with significant rate of hypoglycemia. More recently, the ACCORD trial, a 10,000 patients in the United States that were randomized to very strict glycemic control to try to achieve a hemoglobin A1C less than 6%. And of course, similar to the UK PDS, you have with the standard intensive therapy trying to achieve hemoglobin A1C less than 6 was associated with 3 to 4-fold increased risk of mild to moderate hypoglycemia rate. This is another study with 3,000 patients throughout the VA medical centers in the United States. And you see that even in the first year, second year, and third year, the rate of hypoglycemia increased by somehow 2 to 3-fold throughout the years. And unfortunately, those episodes of hypoglycemia were associated with increased risk of cardiovascular events. Here in the top part of the slides are prospective randomized control studies, and in the bottom, several retrospective studies. And overall, a meta-analysis of almost a million people that were followed up to 5 years showed that the risk of hypoglycemia is associated with significant increased risk of cardiovascular events. And not only cardiovascular events, but also death. And you have here the advanced, origin, devout, night sugars, all of them showing that if you have severe hypoglycemia, the risk of death increased by 2 to 3-fold. And this risk of problems, cardiovascular events, depends on the individuals. So if you have somebody with long duration of diabetes or known cardiovascular disease, there is an added risk of hypoglycemia exposure and hypoglycemia-related complications. I don't have time to go on the mechanisms, but there is a large number of studies have suggested that the hypoglycemia is associated with inflammation, oxidative stress, endothelial dysfunction, and increased sympathetic response, leading to cardiovascular events. So the world in 2008 to 2017 put in the scale efficacy and safety. Efficacy, bringing the hemoglobin A1C down, safety, prevention of hypoglycemia and its related complications. So what had happened since 2017? That we moved to now cardiovascular prevention and renal protection because we finally have data from randomized controlled trials that the use of GLP-1 receptor agonists, different studies, and the SGLT2 inhibitors have some cardiovascular and renal protection. Let me review very briefly an overview because this is going to be discussed in detail by the next few speakers today and tomorrow on the benefits of these new agents. So we have 4 large studies with GLP-1 receptor agonists. We have the liraglutide, the semaglutide, albiglutide, and dulaglutide, all of them showing benefits. So the first study was the liraglutide. The LEADER study was published now just a few years ago, 3 or 4 years ago, that showed that the use of liraglutide added to conventional therapy in high-risk individuals reduced the risk of major cardiovascular events that involve cardiovascular death non-fatal myocardial infarction and non-fatal stroke, but somewhere around 13 to 15%. And to the right of this slide shows cardiovascular death. Adding a GLP-1 reduced cardiovascular death by 22%. Similarly, the second study with GLP-1 is called the SUSTAIN-6 that involves the use of semaglutide. And similar to what was discussed before, you have an impact of 25% reduction in major cardiovascular events, myocardial infarction, cardiovascular death, and stroke. And you see the benefit here in the right upper quadrant of myocardial infarction, strokes, and at the bottom, the death for cardiovascular cause. Similar to these two studies, albiglutide, that now is not available in the United States, also showed a significant benefit with 22% reduction of cardiovascular death, cardiovascular mortality for any cause, myocardial infarction, or stroke. And the last study was the dulaglutide that was just published last year. And these studies also show a complete benefit of dulaglutide. So semaglutide and dulaglutide and albiglutide are once weekly, liraglutide once a day. And what we're seeing with the GLP-1 receptor agonists is that the use of these agents on a daily or weekly basis have cardiovascular benefits in those patients who have a high risk of complications. A similar story has evolved during the last 5 years with the use of SGLT2 inhibitors. And we have major trials. I just listed here the empagliflozin with the EMPA-REG, canagliflozin with CANVAS, and the CLARE with dapagliflozin. All of them are cardiovascular outcome trials, and they really shows a complete benefit with reduction of major cardiovascular events somewhere around 20% in patients who have a high risk of complications. Not only that decrease major cardiovascular event, heart attack, stroke, death, but perhaps one of the most important lessons that we have learned is that the SGLT2 significantly reduce the readmissions and death in patients who have history of heart failure. And here you have the EMPA, CANVA, DAPA, all of them reducing the risk of readmissions for heart failure into the hospital in patients who have a heart failure. And the DAPA heart failure also shows that in patients who have low ejection fraction, it reduced the risk of death by about 20%. Not only is cardiovascular events, but these two agents, the SGLT2s and the GLP-1, have shown beneficial effects on kidney function. And all of them have shown a significant reduction of progression, of decline of renal function, or increased creatinine, or decreased GFR. They all have shown a decrease in albuminuria and the need for dialysis. I'm just listing here EMPA, but the same data has been shown with all of the SGLT2s. Similarly, with the GLP-1 receptor agonists, both semaglutide, liraglutide, and in this case, dulaglutide, have been shown that they compare to insulin therapy, shown here in green, what you see to the left, a progressive decline on renal function, on GFR. And here you have that dulaglutide at the lower and the higher dose kind of slow down this progression. And to the right is the albuminuria. So we have now good data that these agents have changed the way we manage patients. And this resulted in the change in 2018. I was a member of the ADA standard of care when we modified the therapy. And we still recommend metformin as the first line agent. And if you start therapy with metformin, 3 months later, you look if you are at goal or not. And then if you are not at goal, you decide what the hemoglobin A1C is for your patient. But if you're not at goal, you have to ask yourself, does my patient have atherosclerotic cardiovascular disease? And the answer is yes. You should consider an SGLT2 or a GLP-1 as the second line agent. If the answer is no, you can still go to the same pathway that we had gone during the last 20 years, and then you can use all of the other agents listed at the bottom of this slide. Now, in the year 2020, the current recommendation is that we went further. And if you have a patient who has history of atherosclerotic cardiovascular disease or renal dysfunction, then you're going to use, if the patient has atherosclerotic cardiovascular disease to the left, you can choose a GLP-1 or an SGLT2. And if the patient has history of heart failure, SGLT2 is the agent to be preferred. GLP-1 does not, receptor agonists do not decrease the risk of readmission for heart failure. SGLT2 is indicated in all of these patients. And this is the algorithm of the American College of Endocrinology. We still consider metformin as the life first agent, but GLP-1 and SGLT2 if you cannot use metformin. And for the second and third agents, combination therapy, you still have GLP-1 of SGLT2. It doesn't matter if you use SGLT2 or GLP-1. The other thing that we're considering for this year, because we are writing the guidelines for next year, is that look at the hemoglobin A1C to start. If you have a hemoglobin A1C less than 7.5, monotherapy. If you have a hemoglobin A1C greater than 7.5, we would like you to consider a combination therapy. Don't wait until the hemoglobin A1C is 9 or 10 to start combination therapy, because recently we have the VERIFY trial. The combination of metformin and the DPP-4 really decreased improved glycemic control over long periods of time. So the American College of Endocrinology is pushing for combination therapy early on. And the final thing that is new for this year for us of the American College of Endocrinology, if you have a patient with atherosclerotic cardiovascular disease or history of heart failure, or you have nephropathy, you should consider GLP-1 or SGLT2 early on, independent of the hemoglobin A1C. So because these agents, in addition to produce the reduction of hemoglobin A1C, improvement of glycemic control, independent of glycemic control, this agent reduce the risk of major cardiovascular events. Of course, we have a multinational meeting today. We have to consider cost. That's right. And in those we have cost is the major issue. We still have agents have been shown to be successful in the treatment of diabetes. So where have we been in the last few years? We went from efficacy, bring the hemoglobin A1C down. We went to safety, and there was this confusion. Of course, safety overcomes efficacy. But now we have that the use of GLP-1 and SGLT2 should be considered for patients who are at high risk. And on my final slides, let me give you my thought about where we are. So the data so far would suggest that if you're looking for prevention of microvascular complications, that is directly related to glycemic control. And here in the blue says you're looking for microvascular complications, just bring the hemoglobin A1C down independent of any agents. All of them will achieve that. But if you want to prevent cardiovascular disease and perhaps renal disease, this is drug strategy dependent. So we have agents now that have changed the way we manage patients with diabetes. And with this, I thank you very much for your attention.
Thank you, Professor Umpierrez. That was a wonderful overview on how you have selected the various therapies and how the algorithm has evolved over the last 20 years. We have a lot of questions from delegates across the globe. I have screened a few of them. The first question from one of the delegates from the Middle East is, if you have a patient who has atherosclerotic cardiovascular disease, and he's on a DPP-4 plus metformin and very well controlled at an HbA1c of 6.5, would you remove his DPP-4 and add a GLP-1 or an SGLT2 for him?
Yeah, I mean, I have no questions, and this is something that we do on a daily basis. That's right. DPP-4 are safe. DPP-4 are effective, but they have not shown, none of them, and all of them has been trialed to reduce cardiovascular events. So if I have a patient with DPP-4 and the patient has heart failure, I will switch these patients to an SGLT2 independent of the hemoglobin A1C. And I will also consider these patients, in addition to stop smoking, to lipid therapy, aspirin, to consider a GLP-1, especially if the patient is overweight. Now, if the patient doesn't have heart failure, the question is, would you go to a GLP-1 and SGLT2? Well, I'll ask the patients, I'll talk about the side effects, adverse events, then I'll ask the patient, well, do you want a shot every week or do you want a tablet every day?
Okay. Thank you so much for that reply. I hope the doctor from the Middle East has got his questions answered. We have another question from South India. That is hypoglycemia a risk factor for cardiovascular event, or is it a risk marker for a cardiovascular event? What should a clinician consider?
I believe it's both. So there is no question that those who develop hypoglycemia have more likely to have an insulin therapy, long duration of diabetes, multiple comorbidities, and that may favor the appearance of hypoglycemia. But on the other hand, hypoglycemia has been directly related to the increased risk of cardiovascular events. Now, we know that patients, especially in the elderly, hypoglycemia occurs at night, may not be symptomatic, so patients have recurrent episode of hypoglycemia. We should take hypoglycemia very seriously. So if you're taking somebody with metformin sulfonylureas and the patient has hypoglycemia, stop the sulfonylureas immediately or adjust the dose of insulin, because what we want in this group of patients is to have mild to moderate glycemic control, avoid hypoglycemia, in way we can prevent long-term acute and long-term complications.
Thank you so much, Dr. Umpierrez. There's another question from the eastern part of India, that in the elderly type 2 diabetics, patients above the age of 70, what would be the first choice drug? What would be the drug of choice to start off?
So late last year, the Endocrine Society, we published a recommendation for glycemic in the older adults. And I think they're very practical. So you should divide these elder adults in three groups. The healthy adult, for example, somebody in the 60s, 70s, and is very healthy, is different from those who have comorbidities who is very ill. So you have to look at who is in front of you. And then you have two groups of medications. Those medicines that are associated with increased risk of hypoglycemia and those medicines who not. Of course, the medications associated with increased risk of hypoglycemia are sulfonylureas and insulin. So many times you used to have insulin, sure, but sulfonylureas in the elderly has to be titrated very careful if you want to use it. And if the patient have complications, is at risk of hypoglycemia, should never be used, because now we have medicines that have been shown to have the same effects, decreasing hemoglobin A1C with no risk of hypoglycemia. So the elderly or the older adult, I don't know what is elderly, but the older adults over the age 65, 70, you have to individualize care, individualize who is the host, and see which agent you should use.
Thank you so much, Professor Umpierrez. That was a wonderful discussion.
And I want to ask some more questions. Rajiv, let me just think a couple of questions people have. Dr. Guillermo, one thing that stands out is, of course, all this while in all the algorithms, we've had lifestyle and metformin, and the pre-diabetes has been a section which has always been, a big question mark, that what should we do to, other than metformin, that can change the pathophysiologic process so that, you can deal it on the beta cell failure. According to you, do you think we can use any of these agents other than metformin in pre-diabetes?
So this has been a very hard question to answer during the last 2 decades. And we have discussed this with the ADA, Endocrine Society, and with you in India. So what agent you should use for prevents the progression of prediabetes to type 2 diabetes. Every agent has been tested, and all of them work, except sulfonylureas. Sulfonylureas have never been shown to decrease the progression from prediabetes to diabetes, but metformin works, decreasing the risk by about 30–40%. TCDs even better, 50–70%. And now we have with the GLP-1 also data, even the weight loss medicines. So if you decrease the load of insulin resistance or you improve insulin secretion, you're going to prevent the progression to type 2 diabetes, or maybe slow down the progression to type 2 diabetes. The other thing that we have learned, if you stop the medicine, you will progress to type 2 diabetes. So the effects on the beta cell with preservation of the beta cell is not what we thought we were going to get. Maybe it's a treatment effect.
But do you think there is a scope to start a SGLT or a GLP-1 in patients who've got pre-diabetes? I mean, according to you, do you think in future the algorithms will include it?
So in the United States, metformin is $4 a month. These agents are $4 to $8 a day. So it doesn't justify the use of these agents because the effects on progression to diabetes is about the same. And more importantly, if the patient with prediabetes have heart failure, I'll use an SGLT2 because the FDA in the United States has approved the use of SGLT2 for a patient with or without diabetes, especially if they have low ejection fraction, because that's been associated with decreased risk of death and decreased risk of readmission to the hospital. If we're going to use an agent for prediabetes not to progress to diabetes, metformin is the drug of choice if you're going to use medications. Of course, diet and exercise is the paramount, is the most important intervention that we can ever do.
Can you start an SGLT2 inhibitor like a CAN or a DAPA post-stroke patients? What is your thought about it?
So these agents have been shown to be effective. That's right. It decreased volume. It decreased blood pressure, and very effective. Now, for stroke patients, you have from pioglitazone. The IRIS trial has shown to decrease the risk of strokes again in these patients with prediabetes and stroke. Pioglitazone would be very high on my list. I think that if the patient has stroke, if no diabetes, I would not indicate to use an SGLT2. I would use aspirin, I would use Diclofenac, some other medicine to control the blood pressure. If the patient has diabetes, well, in that case, that would be an indication.
Looking at today's time, where do you really, because all the algorithms have pushed sulfonylureas at the bottom. I mean, I would put the ACE algorithm, and you're on the board of ACE, you're on the writing committee of ACE, and you look at the ADA2. Today, I mean, sulfonylurea is an important drug in many parts of the world, considering the costs involved. According to you, where would you fit, use of sulfonylureas in practice? I mean, a lot of people are clinicians. A lot of advocacy is going for SGLT2, GLP-1s. And are we really saying that sulfonylureas, are going to limit itself to a very specific population of people?
So the use of sulfonylureas is widely used everywhere in the world. In the United States, about 30% of patients are on sulfonylureas. And I think it's going to continue to use because, as you said, are effective, are cheap, and they're safe for most people. But however, if I ask you the following question, if all the medicines available for the treatment of type 2 diabetes will cost $5, all, would you use sulfonylureas or not? Likely no. You push it to the end. Now, we are obligated, and I've seen patients in the community hospital with 34% of my patients have no insurance, and they have to pay out of pocket. And I do use sulfonylureas with metformin, and many times I use ethosolidinedione. And I'm forced to use human insulin instead of the analog because they have to pay out of pocket. Now, if I use sulfonylureas, I'll use carefully. We've never used glyburide, but I will select glimepiride, glipizide. We don't have glycoside like you have in your country. So glimepiride had been shown, according to the Carolina trial, to be effective. Produce hypoglycemia, no question, but it was not associated with increased risk of death or cardiovascular events. So I agree with you, sulfonylureas are still to be used, but if cost will not be a concern, I don't think that we will be having this discussion right now.
Okay. With a number of clinical trials coming justifying each molecule in SGLT2, it's rather confusing that if I have to start a patient on SGLT2, all the effects that you see, cardiovascular outcomes or other, glycemic control or weight, is there a preference that you have for a particular SGLT2 over the other? It's kind of confusing in the minds of the clinician that, which one should I start the patient on? So is there a kind of a simplified version that you can give us that, what should be started?
So in the year 2018, the American Diabetes Association mentioned that you should use this agent versus the other, EMPA, because it have back information. We didn't have information on CANA, on DAPA at that time. This year and last year, we deleted that section. The same thing for the American College of Endocrinology. We deleted a preference. I think it's a group effect. It's a group effect. We're going to have the presentation of ER2 at the American Diabetes Association, ER2 gliflozin, the last one in the group, that also shows some benefit. But we don't know the results of this trial. I believe that the GLP-1 and the SGLT2 is a group effect, with some minor difference in the results of the different studies, that in part may be because of the molecule, but more likely is the type of patients, the population that were involved in the different studies. The SGLT2, all of them were, to me, in the same way, no preference in reduction of hemoglobin A1C, the same effects on weight loss. Maybe there is a group effect. With the group of GLP-1, now we have oral and more potent GLP-1 like semaglutide. But in this country, we have some problems using orals. That's right. We're just learning. You have to give it with an empty stomach, no eating for 2 hours. Don't take it more than with half a glass of water because it dilutes and dislodges this molecule from the mucosa of the stomach. So, and because they use an accelerator for absorption, the PK/PD of other medicine like thyroid hormone may change. So we're just learning to use them, but I think the beneficial effects is there for all of them.
What is your thought about dual SGLT1 and SGLT2 inhibitor, the tirzepatide and the new group of drugs that are still in the trial phases? We did one at our end. So, what is your thought about the dual SGLT1 SGLT2 inhibitors?
Yeah, and I serve in the steering committee of 7 trials with sotagliflozin for patients with type 2 diabetes. So, sure, tremendous beneficial effect. That's right. If you can block both the type 1 and type 2. Type 2 works in the renal tubule and one in the gastrointestinal tract. So you decrease the absorption of glucose in the kidneys and in the gastrointestinal tract, and you flush glucose in the kidneys. Perfect combination. Unfortunately, in type 2, we didn't see much difference compared to SGLT2 alone. And for patients with type 1, increase the risk of diabetic ketoacidosis in the same way the SGLT2 do. So the FDA have denied the approval of these agents for patients with type 1, patients with type 2, and now Lexicon, the company who's driving this, is trying to keep going to completing the trial for cardiovascular events. But I don't see much right now of tremendous benefit of the combination compared to SGLT2 alone. So it looks like the effects on the kidneys overcome the potential effects of the gastrointestinal tract.
I heard your COVID lecture some time back, and obviously the therapeutic regimes for diabetes keeps, shifting the goalposts. There's been a lot of talk about SGLT2 inhibitors use and metformin use. I think there's a little confusion there. So do you think you can, in very, short, summarize as to how somebody should, treat their diabetic status during this COVID epidemic?
Yep. Well, patients who are admitted to the hospital, most of them, well, before they are admitted to the hospital, I just think the main recommendation is to advise patients to do frequent monitoring in the way that there have been many publications on deterioration of glycemic control. So keep track of your glucose testing. Make sure that you follow the sick day rules. You have type 1 or type 2 diabetes and adjust the medication accordingly. Continue the same therapy that you're using in this patient if they are outpatients, and maybe you need to adjust the medicines. In the hospital, most patients are admitted to the floor, but about 20% require ICU care. If you go to the ICU, you may need insulin. But instead of giving continuous insulin infusion that requires glucose monitoring every hour, what we're doing is give basal insulin alone, and we cover these patients every 4 to 6 hours with rapid-acting insulin. The most important thing is that you have to prevent tight glycemic control. Just keep the glucose less than 180, 200, 180 should be enough to prevent the complications of hyperglycemia. And we would prefer to use basal insulin plus corrections in the ICU, although it may need to have continuous insulin infusion. The problem is that you require more finger sticks, you require more PPE, protective equipment, where not everywhere. So the second thing that we're doing is that on the floor, we use basal plus correction as the drug of choice. You can also use basal plus DPP4 in these patients. It works very, very well. And basal plus DPP4 is widely used in New York, in Michigan, and Atlanta as the drug of choice, as the combination of choice for these patients and other patients.
Wonderful. That, I think, was a very good summing up of the treatment during COVID times. I think I just have quick 1 or 2 questions more before we end the session. There's somebody who's asked us that, can you give SGLT1 inhibitors during Ramadan? What is your thought about that?
Yeah. There are several papers that reported on the beneficial effects of SGLT2 during Ramadan. So the mechanism of action of these agents is independent of insulin. So it flushes glucose in the urine. So it does not relate to hypoglycemic effect. And there are 2 or 3 publications that we recently summarized this month, last week, in the British Medical Journal, Diabetes Research and Care, that I'm the editor, on a publication on Ramadan and what are the agents. And I think you can use it. Now, you have to be careful that if you start the agent, many patients develop decreased volume temporarily because of the increased flush of urinary output. And in that case, it may also decrease the blood pressure. So it's not a good thing to start the medication right during Ramadan if they're not going to be eating. But if you can use these agents ahead of time and make sure that the patient is not having any side effects, it should be fine to continue these agents. Now, there's also the risk of diabetic ketoacidosis during fasting. But fasting occurs only when you are not eating for more than 24 hours to see a rise in free fatty acids. And most people in Ramadan have eaten twice a day. So they should replete glycogen stored, and the risk of diabetic ketoacidosis had not been shown to be increased during Ramadan with the use of SGLT2 inhibitor in patients with type 2 diabetes. In patients with type 1, I do not recommend the use of SGLT2, especially if you're not eating well because of the risk of diabetic ketoacidosis.
Is there a role for using a combination of GLP-1 and SGLT2 inhibitors? The cost can be very, very prohibitive. But would there be a specific indication to use this besides obesity?
Yeah, there are a couple of new trials, and of course, it's very appealing, that's right. It both produce weight loss, one decrease appetite, the other flush glucose, one increase insulin, the other does not, one suppress glucagon, the other maybe no change or mild increase in glucagon, but the effects is there. And combination therapy is okay. if you have the money to pay. I think that in the United States, this combination would be somewhere around $1,500 a month, where very few people will be able to afford it. But there is there, and I've seen many patients doing very well. And that's something that you should consider if in certain patients, in certain very selective patients, there is no reason why not you cannot use them together.
I'm going to ask just one last question to you. If you had a crystal ball in your hand and you were to predict the outcome of the great trial, what would you think the choice would be after metformin?
So this month in Diabetes Care, there is a paper on the effects of weight loss with metformin, and it was effective producing weight loss. We don't have the results, but I think that all of them are going to be very similar. If this is remember, this is a group of people who had early diabetes or no therapy or low dose metformin, and they were maximized metformin up to 2 grams. And what the paper in Diabetes Care this month shows is that the increase in the dose of metformin has beneficial effects up to 2 grams. So I think that combination therapy is highly effective. Highly effective. I will anticipate the combination of metformin sulfonylureas result in more hypoglycemia, but no major increased risk of cardiovascular death because these are not high-risk individuals. I will anticipate that the use of metformin with the GLP-1 is there. Unfortunately, great that not include SGLT2 as one of the arms. So at the end, we're going to spend large amount of money, and the study is not going to be much a greater contribution to our knowledge of diabetes care because the combination therapy has been very well established that it worked very well.
I'm going to ask Rajiv if he's got any further questions, but before I stop, do you think the verified trial now is going to start people thinking and we start changing the algorithms, lifestyle, and then, doesn't work, you start with an early combination and not go only metformin?
Verified trial used combination therapy in DPP-4 and metformin. Unfortunately, it used vildagliptin that is not available in the United States, but it's available in your country. It's twice-a-day medicine. But I think all of the DPP-4 are the same. So I do believe that a combination therapy is very effective and should be used in patients who have hemoglobin A1C greater than 7.5. We just revised that section for next year ACE algorithm, and I'm truly believe that early combination therapy have long-term beneficial effects than the treat to target process of doing. You start one, you fail, you add one, you fail, you add 3. Come on, use combination therapy to hemoglobin A1C 7.58, especially in those patients with established diabetes.
Rajiv, you have any further question to ask? Please.
Professor Umpierrez, the combination of GLP-1 plus GIP-1, how exciting and promising does it look?
We have not participated in this trial, but one of the largest pharmaceutical companies working on this combination, and others too, and had been shown to be very effective with weight loss. The problem is the gastrointestinal side effects is present in about 30-40%. So let's see what happened and what's the tolerance of patients with these agents. But there's no question that the beneficial effects of these GIP, GLP-1 has been there. And the preliminary data that was presented at the ADA last year and the EASD and also some early publications suggest that the combination is very effective if you tolerate it.
Thank you, Dr. Umpierrez, and I think we've run out of time. And I would like to say thank you very much. It's been very enlightening to talk to you. The lecture was amazing, and I'm sure a lot of people have a lot of questions still to ask you. But we're going to assemble all these questions and send them answers at a later point of time. I would like to close the session now. The session comes to an end.